Hi everyone, my name's Lottie and I'm a PhD candidate and speech pathologist, and I'm coming to you from Melbourne in Australia. I'll show you a little map on the next slide. So thank you so much for allowing me to present to you via a pre-recorded version of this presentation, as the time differences can be a little bit difficult between Australia and the US, so I really appreciate it. And I'll be presenting to you today on a study on speech and language in Kleefstra syndrome, which is just in the first stages of going through the formal publication process. So really today is a bit of a sneak peek, if you like, into the findings from this study. So this is where I'm based, down in Melbourne in Australia, within Professor Angela Morgan's team. And our team specialises in speech and language and genetics. We're based at the Murdoch Children's Research Institute on the 5th level of this building here, which is housed inside the large children's hospital within Melbourne. So before I get started into more of the results of the Kleefstra syndrome study, I just want to give a little bit of background into speech and language. So speech we can think of as the speech sounds that we make with our mouths. So we can think about, are these sounds clear? We can also think about speech development in terms of milestones. So what's appropriate for an individual's age at a particular point in time in terms of their speech development. So there are lots of different speech disorder diagnoses that an individual might meet criteria for if they have speech challenges. So a more common speech disorder might be an articulation disorder or also stuttering. The last two listed here, dysarthria and childhood apraxia of speech, are motor speech disorders which are quite rare in the general population. And just keep that in mind for when we go through the results of this study a little bit later on. Language, on the other hand, we can think of it kind of simplistically in terms of the vocabulary that we know. So it can be both our understanding and our use of these words in our vocabulary, and also our knowledge of different grammar structures, for example, how we structure a sentence. We can also think of language in terms of our ability to understand, so our receptive language, and our ability to communicate a message to others, so our expressive language. And there, of course, are some disorders or diagnoses, if you like, that kind of sit in between being caused by a speech challenge, caused by a language challenge. And you might have heard of this terminology before, for example, a phonological disorder or a phonological delay. So together, speech and language and everything in between encompasses our communication. But communication is not just speech and language alone. We can also think about different ways of communicating, which is known as augmentative and alternative communication. And from here on, I'll refer to this as AAC. So AAC can be unaided and not use an external system, for example, sign and gesture, or AAC can be aided, and this aided system can be low-tech or non-electronic, or can be high-tech or electronic. And I've got some examples on the slide here you might have seen before. And an individual can use two or more of these different systems, or can use these systems in conjunction with verbal speech. And so you might hear these individuals being referred to as multimodal communicators because they're using more than one mode or more than one way of communicating. So I've got some examples here of two boys with Kleefstra syndrome using different forms of AAC with permission from their families, so thank you for this. The first boy is using unaided AAC in the form of sign language, and the second boy is using aided high-tech AAC in the form of a speech-generating device application on an iPad. So that's an example of some different forms of AAC. So moving on to the findings from the study. So our aim was to recruit individuals from a range of different communication abilities and ages and genotypes, so with those EHMT1 point variances and also deletions that cause Kleefstra syndrome. and also from a range of different language backgrounds as well. So how we did this was all online through caregiver surveys, for which we're very grateful for the generosity of families for completing these and taking their time out of their days to complete these. And also clinician reports, which were provided from families, a speech assessment with English-speaking families with me as a speech pathologist, and also we did some speech recordings, which were available in all the languages on the slide here, which then could be analysed. But I won't present on this last point today, that's a little bit more nitty-gritty. So we worked with clinicians and researchers and Kleefstra syndrome support groups internationally to really get this cohort of individuals with Kleefstra syndrome from a range of different countries. And we ended up with 103 individuals with a median age of around 9.5 years old, which was the largest Kleefstra syndrome cohort to date, and hopefully will be the largest published when we get through to publishing. So we really saw, just to give a brief background, we really saw in terms of genotype, so the type of genetic change which led to an individual's Kleefstra syndrome and the health and medical features that presented due to their Kleefstra syndrome was fairly reflective of what's been reported previously in the scientific literature. And so you can see some of these different points here on this little pink wheel. Just to note, you can see that regression was in 14%. We only measured this based on a caregiver report, and also just thinking about our median age of our cohort being 9.5 years old, just to keep that in mind with some of these different features, including regression, as these might occur after that median age of 9.5 years old. And we did have some adults, we also did have some adolescents, but our cohort was quite young overall. So moving on to the speech and language findings. So you can see here we've mapped out the different types of genetic changes which cause Kleefstra syndrome, and then the different language and social communication and cognition abilities across the group. And you can see that there was a wide range of ability across almost all different genotypes. Apart from those children with larger deletions, there was still a range, but there was no one in the average range with those large deletions. Just to note, individuals with unspecified deletions were mostly comprising of individuals who had had their genetic finding before there was the technology to really identify where exactly the deletion was and what the size of that deletion was, just for that context. And you can also see that language skills do not equal social communication skills, which do not equal intellectual ability or cognitive ability. So for an example here, you can see that there are individuals with splice site point variants who sit within average language and receptive language ranges, social communication as well. But there's no one who sits within the average range of cognitive ability. On the other hand, frame shift variants, there's a number of people that have average cognitive ability, so do not have an intellectual disability, but there's still some individuals, but less, who sit within the average range of language ability. But just to note, whilst the group was quite large at 103 individuals, some of these smaller subgroups were very small, and we're also capturing individuals across a range of different ages, therapy exposures, and other health and medical things that there might have been going on, which might have affected these different domains, just to highlight that. And also it's important to note that when we looked at expressive language skills and receptive language skills, now these were measured by a caregiver assessment tool, which a caregiver completed. There was no difference between expressive and receptive language skills across the group as a whole. There was some difference for some individuals at an individual level, but as across the group as a whole, there was no distinct strengths in one area of language over the other in terms of expressive and receptive language skills. We asked caregivers of children who were verbal and older than 4 years old, so we're using speech and connected sentences, to complete an assessment called the Children's Communication Checklist Second Edition. And from this tool, we can see that there is, again, a range of ability across the group, but that speech is the area that is most challenging for the group as a whole. And that speech was significantly different from most of the other domains. So significantly different, for example, than nonverbal communication ability, semantic skills, social and initiation skills, for example, as well. So you can see the green range on the graph here is average. So there are a handful of individuals in the average and above average range, but the majority of the cohort is sitting below average. And again, speech is really challenging, even in comparison to language skills. And that's why before I wanted to delineate really specifically between what I'm referring to as speech and what I'm referring to as language. So when individuals did a speech assessment with me over Zoom, found that 48 out of 49 individuals had one or more speech disorders. And dysarthria and CAS were the most common form of speech disorder. So thinking back to when I said earlier in this presentation, dysarthria and CAS are quite rare in the general population. For example, in the general population, CAS occurs at about a rate of 1 in 1,000 children. Most individuals in this cohort had dysarthria and or CAS, and co-occurring speech disorders were very common. So often an individual might have had childhood apraxia of speech, so CAS, and also might have had a lisp, which is an articulation disorder. So I've got some examples here of dysarthria and childhood apraxia of speech. So these families have kindly provided me with consent to show these videos today. So dysarthria, as I said before, is a motor speech disorder, as is childhood apraxia of speech. It's neuromuscular of nature and it disrupts multiple different speech subsystems. So this could be your ability to make sound with your vocal folds, your ability to provide breath support, nasality, stress when talking, and articulation, so the clarity of those speech sounds. This is an example of a little girl who has childhood apraxia of speech. She also has some dysarthric features in her speech as well. Just to note that she has a disruption of motor planning and programming, and it is also a motor speech disorder in nature as well. So you can see that she's having difficulty planning and programming and executing that sentence, I'm come your house. So for individuals who did not use speech to communicate, we also looked at communication skills using a caregiver report assessment. And this is called the communication matrix. And the communication matrix breaks up different communication skills into different reasons to communicate. So the communication matrix says that individuals can communicate to refuse, to obtain or ask for more of something, or to get something. They can communicate for information reasons or for social reasons. And the communication matrix covers all these skills because this is what we usually see in typical development, that typically children are able to express all these skills, combining words, by around 24 months old, so 2 years old. And we also look at, I guess, the level of how an individual is communicating this. So are they communicating to refuse by pushing something away, or are they communicating to refuse by saying no, either with sign language or with a gesture or with words, just with single words? So when we look at the group, we saw that there were strengths in an individual's ability to refuse, so to communicate to say no. That was a real strength across the group. Kids with Kleefstra syndrome were really good at communicating to their caregivers when they didn't want something. The next strongest area was communicating in order to obtain. So that was a relative strength. Individuals were pretty good at asking for more of something or making a choice, for example. And just to note that it's not to say that communicating for information or social reasons is a weakness in Kleefstra syndrome. It's just, as you can imagine, by reading some of those dot points in the slide, a little bit more linguistically and cognitively challenging. For example, answering a yes/no question is a bit more challenging than saying no, but also because we commonly focus on refusing or obtaining communication reasons to communicate over information and social reasons, because they're early developing skills and also because they're often a really core focus of speech therapy, whether that's signing for more, for example, or shaking a head to refuse something. So we also asked caregivers about individuals' patterns of AAC use across time. And we saw that just over half the group had had some experience with sign language. So most individuals were using single signs, but there were some individuals who were able to create sentences with signs. There were some individuals as well, about just under 1 in 5 individuals approximately were using a low-tech aided AAC system or a high-tech, or had in the past. And a small proportion of the group had used both a low-tech and a high-tech system. But just to note that almost 1/3, around 1/3, 1/4 of the group were using a combination of different methods at some point or had transitioned across using different methods throughout their lifetime to date. We also looked, again, as I said, with AAC use across time. So caregivers said, for example, my child used gesture when they were under 2 years old, then they used sign language, then they used an aided AAC system. And we saw that aided AAC really increased in usage around about the time an individual would go to school. We saw that early use of sign and gesture was really important, and that multimodal communication, as I said before, was really common. So if you think back to that video of that little boy signing and speaking at the same time, he was communicating in a multimodal way, which means that he had more than one system to rely on to get his message across and also to understand others. So that two-way stream of communication. We also saw that aided AAC use increased with age, so that, for example, an individual's use of some gestures and a bit of basic sign might not have met all their communication needs, for example, well into the school years, so they might have had more aided AAC, so using that external system. And there were many individuals who began using AAC or sign language again after experiencing regression. So of the individuals who had hearing loss, half of those individuals could sign to create simple sentences, and 1/3 of the individuals with hearing loss could sign more complex sentences. And that's just to highlight that sign language is not just for individuals who have some hearing loss, although we know this is a core feature of Kleefstra syndrome. But if we think back to the high levels of motor speech disorders, which can make your speech quite unclear, there is use for that sign language, those sign language skills, even if an individual doesn't have hearing loss. And also we asked caregivers if they thought that AAC would inhibit a child's speech development. So would AAC have a negative impact on an individual's ability to learn to talk? And 1 in 5 or 20% of caregivers said yes. But actually we do know from the AAC literature now and the published research available that this is not the case. And there is actually emerging evidence to suggest that it encourages talking. And we know that AAC can, for example, teach an individual different language and communication skills, like taking turns in a conversation or asking and answering questions, when speech might not meet those needs. So it really helps improve those language skills when speech might not be there yet, and particularly thinking in the case of Kleefstra syndrome with these children who have high levels of dysarthria and CAS, this very well could be the case. So I guess it's really important for clinicians that are working with families to be up to date with this information so that they can provide this to families in a timely manner if it's appropriate for a family. So just as a little summary, what do we know now? So we know that language, speech and cognition really ranged across the group, that there wasn't a significant difference between receptive and expressive language skills. And there were some strengths identified for some genotypes, but there were small numbers in these different genotype groups, so we need further investigation here. In terms of speech, again, dysarthria and CAS and those co-occurring speech disorders are common, and speech disorders are almost ubiquitous. In fact, we know that Kleefstra syndrome is a very varied condition, but having almost all the verbal individuals having one or more speech disorder makes speech disorder a core characteristic of Kleefstra syndrome. And lastly, thinking about cognition. So cognition does not equal speech and language skills. So an individual might have challenges in speech and or language, but might have relative strengths in their cognition. And again, there was a range across the group. We do really need to understand more in Kleefstra syndrome about change across time, because again, this is a snapshot in time, and we know, for example, with some reports of regression for some individuals, that we really need to understand how speech and language and cognition might change, and also, again, how this might develop in the early years. And just to highlight, I haven't presented on this today, as there's only so much one can fit in a presentation, but we did also gather information on, for example, milestones. So when do children speak their first words? When do children begin combining words into sentences? And how this differed across different genotype groups as well. So that will be in the publication when it becomes publicly available. And now moving on to AAC. So I've covered a little bit of this already in my presentation, but sign is commonly used in Kleefstra syndrome, and it's really important in those early years, it seems, or at least it's very commonly used. Multimodal communication is really important, and AAC can support a range of different communicative functions or reasons to communicate to help it develop when speech isn't meeting that communicative need. We also really call for an early implementation of AAC. Because AAC does not hinder speech development at all, it's not encouraged to wait and see if a child learns to speak. Like that little boy in the video I showed you before, we can work on sign language and speech concurrently together, for example, or AAC and speech together in therapy, and they don't need to be mutually exclusive. And we also need to think about in future research and also for families moving forward, how AAC, sign language, or an aided system might play an important role in regression, either in supporting an individual to communicate during or after regression, or supporting an individual's ability to understand, so to support them to understand their environment and decrease distress and things like that as well. And of course, it wasn't just me that was part of this project. There's a massive team of clinical geneticists and family support organisations and speech pathologists. Namely, I just want to name that my two PhD supervisors, Professor Angela Morgan and Professor Ingrid Scheffer, and of course, Professor Chitska Kleefstra, who really identified that this was an area that needed more research in Kleefstra syndrome, and came to the head of my lab, Professor Angela Morgan, to really get the ball rolling with this study. And you can see all the acknowledgements on the slide here that I could go through, but I really are so grateful to all the families who took part in this study, but because without their participation, we wouldn't have found any of the findings that we did from this study. So we are very, very grateful. Thank you so much.